This podcast is specially produced by the Critical Care Education Foundation's Knowledge Hub project for you, with the intention of providing a learning opportunity for doctors. It supplements the other material and self-assessments available on the CCEF Knowledge Hub project. Welcome to the Deep Dive. Today we're plunging into one of the most urgent neurological emergencies you'll face in the ICU, status epilepticus, or SE. This is really a condition where every single second counts. Your swift, precise action as a critical care doctor can, well, it literally mean the difference between life and irreversible brain damage.
That's absolutely right. Status epilepticus is fundamentally characterized by prolonged seizures or repetitive seizures, where a patient doesn't fully regain consciousness between episodes,
Right.
And this relentless activity, it leads to significant neuronal injury and profound changes in brain networks. So our mission in this deep dive is really to equip you, the listener, with a comprehensive understanding of SE, everything from its varied presentations and the diagnostic challenges specific to the ICU, to the latest evidence-based management protocols, and crucially, the central role the critical care team plays in navigating every phase of this emergency.
So we'll map out those critical time points that demand immediate intervention, dissect the different classifications of SE, and then sort of strategically walk through the phased approach to management.
Exactly.
Highlighting the specific medications and strategies to employ at each stage. We'll also look at recent advances that are really reshaping current practice and the indispensable role of continuous monitoring. It's a race, isn't it? And understanding the strategy is paramount.
Let's begin at the very start.
Yeah.
What defines status epilepticus, and why does it command such immediate and aggressive attention from the critical care team?
Okay, so at its core, SE is a sustained seizure state, or you could think of it as multiple seizures without full recovery in between, leading to ongoing neuronal injury. The urgency is dictated by what we call critical time points.
Right, the time points. Yeah, and these aren't just arbitrary markers. They represent real thresholds for intervention and potential irreversible harm. First, we have T1, that's the 5-minute mark.
Wow.
For generalized tonic-clonic SE, this is the absolute deadline for initiating first-line treatment. If you miss this window, you're already playing catch-up.
5 minutes. That's incredibly fast.
It is. Then, profoundly at T2, which is 30 minutes, we hit the point where irreversible neuronal damage starts to set in. This is why rapid intervention by the critical care team is not just, good practice. It's fundamentally about preventing permanent brain injury.
30 minutes for permanent damage. Wow.
And beyond these initial points, we define refractory SE, RSE. This happens in about 20% of cases when both first and second-line therapies have failed.
So the initial treatments didn't work.
Correct. And then even more concerning is super refractory SE, or SRSE. That's where SE persists for more than 24 hours despite continuous anesthetic therapy. These escalating definitions really underscore the progressive and, frankly, increasingly complex nature of this condition.
So it's not merely about stopping the seizure itself, but about this frantic effort to protect the brain from irreversible harm, with the clock ticking relentlessly from the very first minute. It sounds like a complex opponent. How many faces does SE actually have? What are the varied ways it can present, especially in the challenging ICU environment where, clinical signs might be masked?
It's true. SE is far from a single entity, and recognizing its diverse presentations is absolutely critical for guiding our approach. The most common and often most dramatic form is convulsive SE. Here you'll see continuous convulsive activity lasting 5 minutes or more. What's often overlooked but critically important for you in the ICU is the massive autonomic surge that comes with it.
Autonomic surge? Like
Yeah,
what?
patients can display profound tachycardia, hypertension, and hyperthermia. The clinical signs can progress from obvious tonic-clonic movements to very subtle twitching, sometimes even just nystagmus or pupillary changes or a loss of corneal reflexes as things get worse.
Subtle signs.
Yeah.
Tricky.
Very. Then, particularly challenging in the ICU, we have non-convulsive SE, NCSE. Patients often present with a prolonged confusional state, maybe lasting 30 minutes or more, altered behavior, or fluctuating consciousness. The key here is extreme vigilance.
Because the signs are hidden.
Exactly. Signs can be incredibly subtle. Minimal facial twitching, perhaps slight eye deviation, or repetitive blinking. You need a high index of suspicion for any unexplained coma or encephalopathy, especially when other common causes have been ruled out.
Makes sense. What else?
We also encounter focal SE with preserved awareness. Here, continuous focal seizures occur without loss of consciousness. An example is epilepsia partialis continua. This can be highly localized and notoriously resistant to treatment.
Right.
And lastly, anoxic myoclonic SE. This is a severe complication following cardiac arrest characterized by stimulus-induced myoclonic jerks. It typically carries a poor prognosis and requires careful differentiation from Lance Adams syndrome.
Okay, given these subtle and varied presentations, what specific diagnostic hurdles does your team face in the ICU, and how do you overcome them to really pinpoint SE?
Well, in the ICU, certain scenarios automatically trigger a high suspicion for SE post-cardiac arrest patients. Anyone with unexplained coma or altered mental status, those with recent intracranial hemorrhage, or critically, patients on neuromuscular blockade or deep sedation where obvious clinical signs are entirely masked.
Right, you can't see the seizure.
Precisely. This is exactly where continuous EEG monitoring becomes an indispensable tool for the critical care team. It's non-negotiable in these situations. We rely on specific EEG criteria for diagnosis. We look for electrographic SE, which signifies continuous seizure activity lasting 10 minutes or more on the EEG trace, or electroclinical SE, where you see clinical symptoms clearly time-locked to the EEG pattern. Continuous EEG monitoring is now considered standard care for all high-risk patients. And for NCSE specifically, the Salzburg criteria are invaluable. They combine clinical signs lasting 10 minutes or more with specific EEG patterns like epileptiform discharges at or above 2.5 hertz, or slower discharges showing clear spatiotemporal evolution, or, importantly, improvement with anti-seizure drugs. These criteria are essential for accurate diagnosis in our complex patient population.
So once SE is firmly identified, the clock is truly ticking. How does the critical care team then shift into this highly structured, phased management protocol? It sounds almost like a meticulously planned strategic offensive.
It is exactly that, a rapid, aggressive, and highly structured protocol. Time is of the essence. Phase 1. Immediate stabilization, 0 to 9 minutes. This is where you conduct your primary survey and resuscitate. ABCs first. You immediately secure the airway if needed, ensure oxygen saturation is above 94%, establish large bore IV access, and initiate continuous cardiac monitoring. Critically, a bedside glucose check is paramount. You have to rule out hypoglycemia right away.
Glucose first, right? Then meds.
Yes. For first-line medications, you choose one benzodiazepine. Lorafam is often preferred 0.1 milligram IV, max 4.8 milligrams, given in 2 milligram increments, slowly, less than 2 milligram. Its longer duration, 2 to 24 hours, is a big advantage.
Okay, what if you can't get IV access quickly?
Good point. If IV access is a challenge, midazolam 10 milligram IM for adults over 40 kilogram or 5 milligram IM for those 13-40 kilograms is an excellent single injection. Studies show it's actually faster in pre-hospital settings.
Faster than IV. Interesting.
In terms of time to administration, yes. Diazepam 0.1, 0.2 milligram IV is another option, though its shorter duration, only 10-25 minutes, means you need to be ready with the next steps quickly.
And other immediate actions.
Absolutely. Crucial concurrent actions include administering thiamine 100 milligram IV followed by D50, maybe 50 100 milligram IV if hypoglycemia is suspected or confirmed. Immediately draw blood for CBC, CMP, anti-seizure medication levels if they're on them, toxicology screens, and an ABG. And remember, the initial benzodiazepine dose can be repeated once after 5-10 minutes if the seizures are still ongoing.
Okay, that's the first 10 minutes. What's phase 2?
B phase 2. Urgent control therapy, 5-30 minutes. At this point, the goal shifts to preventing seizure recurrence. And these second-line agents, they're administered regardless of the initial response to the benzo. You give them anyway.
Right, don't wait to see if the benzo worked long-term.
Exactly. And the landmark ESET study was really important here. It confirmed that the main second-line agents are equally effective, which gives you crucial flexibility. So phosphonatoin, which is generally preferred over phenytoin due to infusion site issues, gets a loading dose of 20 milligram EP, not faster than 150 milligram PDPN. You might need additional doses up to 30 milligram PP total. Target level, 20-30 pml, continuous cardiac monitoring and frequent BP checks are essential here. Then there's levetiracetam, loading dose of 60 milligram kilom IV, max 4.5 grams over 5-10 minutes. Big advantages, minimal drug interactions, renal clearance. Just need to remember dose reduction if CRCL is less than 50. Then there's levetiracetam, loading dose of 60 milligram IV, max 4.5 grams over 5-10 minutes. Big advantages, valproate sodium is another option. Loading dose 40 milligram IV, max 3 gram infused at 3.6 milligram. Target level for SE is higher, around 80-100 microml. You need to monitor ammonia, platelets, LFTs, and remember it's contraindicated in pregnancy and liver disease. Then there's levetiracetam, loading dose of 60 milligram IV, max 4.5 grams over 5-10 minutes. Big advantages, Finally, phenobarbital, loading dose 20 milligram IV, max rate 100 milligram. Target 40-60 Vig-Gamel. You have to use this one with caution. High risk of respiratory depression, especially after benzos. But it's a strong consideration for alcohol withdrawal SE.
Okay, so ESET says those three, phosphonatoin, levetiracetam, valproate, are basically equivalent in stopping seizures at this stage.
That's the key finding, yes. Around 45-47% efficacy for seizure cessation. So you can choose based on patient factors, administration time, side effects.
What if those don't work? We have 30 minutes, maybe more.
Right. That brings us to C phase 3, refractory SE management, 31 and 90 minutes. By this stage, the patient absolutely requires intubation, mechanical ventilation, continuous EEG monitoring, and full ICU admission, no question. You now shift to third-line anesthetic agents to induce a coma and stop the seizure activity electrically.
Anesthetic agents. Which ones?
Propofol is the most common choice. You'd give a bolus of 1 to 2 millikilokalorie IFE, then start an infusion at 1 to 5 millikilokalorie CRIOR. Titrate it carefully to achieve either burst suppression or seizure cessation on the continuous EEG. A critical point. Avoid doses higher than 5 millitriol for more than 48 hours because of the risk of propofol infusion syndrome, PARI-ARS, monitor triglycerides, lactate, cardiac function closely.
Okay, propofol. Any others?
Yes, midazolam can be used as a continuous infusion too. Bolus buto 0.1, 0.2 milligicals IV, then an infusion of 0.1, 2.0 milligicals stable-hour. It offers potentially better hemodynamic tolerance than, say, pentobarbital, but be aware that tachyphylaxis, where it becomes less effective over time, can develop after 36-48 hours. You might need to consider switching if control isn't achieved after 72 hours.
And pentobarbital, you mentioned it.
Pentobarbital is another option. Loading dose 515 milligicals IV, then an infusion of 0.5 to 5 milligicals. The EEG goal here is clear burst suppression, 10 seconds of suppression, then 1-2 second bursts of activity. But it often demands aggressive hemodynamic support with vasopressors due to significant hypotension. It also carries risks of ileus and immunosuppression. It's effective, but comes with baggage.
So managing these infusions is complex. How long do you keep them going?
The general anesthetic management protocol involves inducing a state to achieve seizure suppression on the EEG, maintaining that suppression for 24 to 48 hours after the patient is seizure-free, and then gradually weaning the infusion over 6-12 hours, all while watching the EEG continuously. If seizures recur during the wean, you restart the infusion for another 24 hours.
Wow. And if even that doesn't work, seizures persisting past 24 hours on anesthetics.
That's when we enter D phase 4, superrefractory SE, SRSE, defined as SE continuing for 24 hours or more despite anesthetic therapy or recurring on withdrawal. For SRSE, you explore advanced, sometimes less conventional therapies.
Like what?
Well, ketamine is gaining significant traction. It's an NMDA antagonist, which is relevant because those receptors change during prolonged SE. Bolus 0.53 milligicals, then an infusion of 110 milligicals. An interesting point is that it might actually reduce vasopressor requirements compared to other anesthetics because of its sympathomimetic effects. And there's growing evidence that using it earlier, within hours of becoming refractory, might be more effective.
Ketamine. Interesting. What else is in the SRSE toolbox?
Immunotherapy is essential if you suspect an autoimmune or cryptogenic cause, like in Norse. This includes high-dose steroids, typically methylprednisolone 1 gram daily for 3 to 5 days, IVA, or even plasmapheresis. The ketogenic diet is another option, indicated for SRSE, particularly in pediatric cases, but also used in adults. The goal is to achieve ketosis, aiming for a kinfardoxybutyrate level of 3 to 5 millimol. And finally, hypothermia, targeting 30 to 35 degrees C for 12-48 hours, has been tried, though the evidence is currently limited mostly to case reports in small series.
So beyond the seizure itself, what are the common underlying causes of STAR your team must pinpoint, and what are the crucial systemic complications you're simultaneously battling in the ICU?
Identifying the etiology is absolutely paramount, as it often dictates specific, targeted management alongside the anti-seizure meds. Common causes we see in the ICU include medication noncompliance, surprisingly frequent in patients with known epilepsy. Stroke, both ischemic and hemorrhagic, accounts for a big chunk, maybe around 22% of cases. CNS infections like meningitis, encephalitis, or brain abscesses are also common culprits. Metabolic derangements, think hyponatremia, hypoglycemia, uremia, must be swiftly identified and corrected. And don't forget drug toxicity. Certain antibiotics like cefepime or carbapenems, theophylline, immunosuppressants like tacrolimus can lower the seizure threshold. And some drugs can directly induce SE, high-dose penicillin, tacrolimus, cyclosporine, tramadol, even tranexamic acid in susceptible individuals.
Good list to keep in mind. And the systemic fallout.
Right. Beyond the neurological crisis, your critical care team must actively monitor and manage a potential cascade of systemic complications. For the cardiovascular system, early SC can cause hypertension and tachycardia from that adrenergic surge we talked about. But later, hypotension, dangerous arrhythmias, or even cardiac arrest can occur, demanding continuous monitoring and often vasopressor support.
Respiratory issues.
Definitely. Respiratory complications like aspiration pneumonia, neurogenic pulmonary edema, and ARDS are significant risks, often necessitating mechanical ventilation and diligent VAP prevention strategies. For renal health, you need to monitor for rhabdomyolysis from the intense muscle activity and subsequent acute kidney injury, managing primarily with aggressive hydration.
Metabolic and temperature.
Yeah, metabolic complications are frequent. Early on, you often see hyperglycemia and metabolic acidosis, which usually self-resolve. But later, hypoglycemia can occur, and ongoing derangements need close monitoring and tight glucose control. Lastly, hyperthermia is common and requires aggressive cooling to keep the temperature below 38.5 degrees C using cooling blankets or other methods. Your role as a critical care doctor here is truly holistic. You're managing the entire patient systemically, not just the brain seizure.
It's clear this field is constantly evolving. What have been the most impactful recent advances in AC management that critical care doctors absolutely need to be aware of? How do they concretely change how you practice at the bedside?
That's a great question. The last few years have indeed brought significant evidence-based shifts that have profoundly refined our approach. Let's highlight some real game changers. The ESET trial, with validation ongoing into 2024, definitively confirmed what many suspected. Levetiracetam, fosphenytoin, and valproate are all equally effective as second-line therapies. Efficacy rates were around 45–47% for all three.
So no clear winner among those three.
No clear winner in terms of efficacy. This is a huge takeaway. It provides you, the critical care doctor, with significant practical flexibility. You can choose based on patient factors, how quickly you can administer it, side effect profiles, cost, availability, rather than chasing a theoretical superiority that just isn't there.
That simplifies things a bit. What about before the hospital?
For pre-hospital management, the Rampart trial was a true paradigm shift. This trial, validated between 2012 and 2024, showed that intramuscular IM midazolam is actually superior to IV lorazepam for pre-hospital SE, faster time to seizure cessation.
IM better than IV.
In that specific pre-hospital setting, yes, largely because getting IM access is faster than establishing IV access in a seizing patient. This led to its FDA approval in 2018 and widespread adoption. Think about it. Getting medication into a seizing patient quickly without needing immediate IV access can be life-saving.
Makes perfect sense. Any new drugs on the horizon?
Yes, a newer development from the RACE trial in 2024 introduced ganaxolone. It's the first novel mechanism drug showing real promise in refractory SE. It achieved an impressive 80% seizure cessation within 30 minutes in its primary endpoint. It's a GABA receptor modulator, offering a crucial new therapeutic avenue for those really tough-to-control cases.
Ganaxolone,
Yeah.
one to watch. And ketamine, you mentioned it for SRSE.
Yes, since around 2021, evidence for ketamine has been steadily growing. Multiple reviews now show it decreases seizure burden in about 81% of super-refractory SE patients, achieving complete cessation in around 63%. Its NMDA receptor antagonism is key because it targets mechanisms relevant in prolonged SE. And critically, its sympathomimetic properties can reduce vasopressor needs, offering a hemodynamic advantage over other anesthetics. Emerging data suggests earlier use, perhaps within hours of becoming refractory, might be more effective.
Okay. And NORS, new onset refractory status epilepticus.
Crucial updates there. NORS is now recognized as a distinct entity SE in patients without active epilepsy and no clear acute cause. Autoimmune encephalitis is identified as the most common cause in about 37% of cases where a cause is found. What's vital for you to know is that early immunotherapy is critical. It shows 73% seizure control when initiated within 2 weeks. Your team absolutely should not wait for antibody results to return if NORS is suspected. Time is brain. Start the immunotherapy.
Don't wait for the tests. Got it. How does all this translate into guidelines?
These advancements are reflected in updated guidelines. You see an evolving consensus. Midazolam, often IM, intranasal, or buccal, is a primary first-line choice alongside IV lorazepam or diazepam. Second-line agents clearly reflect ESET's findings of equal efficacy. The refined treatment timelines reinforce those critical phases we discussed. 0–5 minutes for the benzo, 5–30 minutes for second line, 30–60 minutes for third line anesthetic or ketamine, and beyond 24 hours for novel therapies and SRSE.
And practically in the ICU.
Practically. Continuous EEG monitoring is now standard for all RSE patients. Ketamine offers that potential hemodynamic advantage in refractory cases. And for Norse fires, initiate first-line immunotherapy within 72 hours if suspected, and consider second-line immunotherapy within the first week if seizures persist despite initial treatment.
Knowing all this, what factors ultimately influence a patient's outcome in SE? And are there specific considerations your team faces for particular patient groups?
Prognosis in SE is, unfortunately, dictated by several key factors. In terms of mortality risk, certain high-risk etiologies like anoxic brain injury carry the highest mortality rates. The duration of SE itself is paramount. Convulsive SE lasting more than 30 minutes significantly increases mortality. And age, particularly over 70 years, is consistently associated with worse outcomes. Overall mortality for convulsive SE hovers around 20%, while for NCSE, it's a wider range, maybe 17% up to 57%, depending on the underlying cause and patient factors.
And if they survive the acute episode?
For long-term sequelae, survivors often face significant challenges. Things like cognitive impairment, memory deficits, the development of chronic epilepsy later on, and focal neurological deficits are common. Your early, aggressive intervention as a critical care team plays a profound role in mitigating these long-term consequences and shaping the patient's future quality of life.
Are there specific populations needing different approaches? Pregnancy, kids?
Yes, absolutely. Special populations require tailored approaches. In pregnancy or eclampsia, magnesium sulfate is the first-line treatment of 4,6-G IV bolus, then an infusion of 1 titerater. Levetiracetam is generally preferred as a second-line anti-seizure agent due to its relatively favorable safety profile in pregnancy.
Okay, pediatrics.
For pediatric considerations, while dosing is generally similar per kilogram, alternatives for IV access are crucial. Things like buccal or intranasal midazolam or rectal diazepam are common. It's also vital to administer pyridoxine, 100 milligram IV, for infants and young children, particularly if an inborn error of metabolism is suspected as the cause.
And alcohol withdrawal.
Alcohol withdrawal, SE. Lorazepam, potentially requiring higher doses, is first line. Phenobarbital is often preferred as a second-line agent here, maybe more so than in other types of SE. And concurrent administration of thiamine, folate, and multivitamins is absolutely essential to prevent Wernicke-Korsakoff syndrome and other complications.
Finally, what are the quality metrics that truly guide your critical care team's performance in SE management? And what does the long-term journey look like for patients after they leave the relative safety of the ICU?
Adherence to those time-sensitive targets we discussed is a non-negotiable quality metric for your team. It's how we measure success. This means initiating first-line therapy in less than 5 minutes from recognition, administering second-line therapy in less than 30 minutes from onset, initiating EEG for suspected NCSE in less than 60 minutes, and starting anesthetic or ketamine treatment in less than 90 minutes if the SE proves refractory. These are the benchmarks of excellent care.
And documentation.
Essential documentation by your team must include the precise seizure onset time and a good description, the patient's response to each therapeutic intervention, the EEG findings and how they evolve over time, any complications encountered and how they were managed, and clear trends in the neurological examination. Meticulous records are key.
What about getting them out of the ICU?
For long-term care, there are specific ICU discharge criteria. The patient should be seizure-free for 24-48 hours off anesthetic infusions, hemodynamically stable, free of active complications requiring intensive monitoring, and have an appropriate maintenance anti-seizure medication regimen firmly established.
And after discharge?
Post-discharge, the long-term management is crucial. It involves follow-up with epilepsy or neurology specialists, usually within 1-2 weeks. Ongoing anti-seizure medication level monitoring and optimization is needed. An MRI of the brain should be done if it wasn't performed acutely. Neuropsychological evaluation is often necessary to assess for cognitive concerns. And of course, driving restrictions need to be discussed and implemented per local guidelines. Your team's early, aggressive, and highly coordinated intervention in the ICU significantly impacts these long-term outcomes and the patient's ultimate quality of life.
What an incredibly detailed and truly critical deep dive into status epilepticus. It's undeniably clear that the critical care team plays an absolutely pivotal, time-sensitive role in managing this emergency, from that initial stabilization through super-refractory care and the continuous vigilance over all those systemic complications.
Indeed, the landscape of SE management is evolving rapidly, isn't it? With landmark trials refining our approach to drug selection and the precise timing of interventions. For you, the critical care doctor listening, embracing these advancements, maintaining that high level of vigilance, committing to continuous learning, and ensuring meticulous documentation that is truly key to improving patient outcomes.
And perhaps the biggest takeaway here is that while SE is a complex and frightening neurological emergency, the consistent, disciplined application of a phased, evidence-based management protocol by a skilled critical care team really does make the difference. It prevents irreversible damage and shapes a patient's long-term prognosis.
It truly does. And, it makes one wonder, as our understanding of SE deepens, and with emerging therapies like novel receptor modulators coming down the pike, how much closer are we to truly personalizing treatment protocols for each patient? Can we eventually move beyond the current algorithms towards a kind of precision medicine, perhaps guided by individual patient biomarkers or unique genetic insights? That's a profound question the critical care team of the future will continue to grapple with.
A truly thought-provoking question to leave us with. Thank you for joining us on this deep dive into status epilepticus. We hope this has provided you with a clear and comprehensive understanding of this critical topic.